Hi, and welcome to another video from the D.I.D clinic. My name is Dr. Mike Lloyd. Today I'm going to be discussing an issue that has been raised by a few comments made on the channel in the feedback section. So people have been asking about how denial works in dissociative identity disorder, or D.I.D, and also why is it that some people only get diagnosed quite later on in their life, so maybe in their 40s, maybe in their 50s, if this is a condition that largely begins, as we're aware of it, very early in childhood. So certainly by adolescence, D.I.D is either present or it isn't, but it can take someone maybe 30 years, maybe 40 years before they get diagnosed. So I'm going to answer that question today. This is a topic then about denial. It's not denial of the existence of D.I.D, it's denial of the presence of D.I.D within an individual's experience, functioning within the system, whatever we want to call it. So the premise is that D.I.D exists in a person, has done for a long time, but somehow it doesn't feel like it's present, or it's being denied either to the individual, to themselves, or being denied to the outside world. So a person may know that they have these symptoms, they may be labelling that they have their own symptoms, but they do not want the outside world to know about it, or they may be repressing those symptoms and acting as if those symptoms are not there at all. One of the first things to think about is it's entirely likely that a person may have amnesia for some of those. It's a key construct of the diagnostic criteria of D.I.D is that amnesia is present to some degree within that person. This means that some traumatic memories may be denied to the self through amnesia. That is, a person may not be aware that they have had these traumatic experiences. They are likely to be aware that there is something amiss, and they may have huge gaps in their childhood which wouldn't be accounted for by ordinary forgetting. For example, a loss of memory of events between, say, the ages of 6 years old and 9 years old, or being in a particular house or being in a particular town they simply have no memories of, but either side of those things memories do exist. So unusual episodes of amnesia along those sort of lines. A person might want to reduce the significance of that trauma. I've had this in clinical sessions where a person has come in for assessment and said that they were abused in childhood, but it's no big deal, it doesn't really matter, it doesn't have any impact on them, and yet what they're talking about in the assessment is symptoms of eating disorders, of self-harm, of personality, of relational issues, many factors, substance issues, many factors, which lead someone like myself as a clinician to believe that there is a huge impact, but the person is minimizing the effect, the impact of that trauma. In a way, it's like they don't want the trauma to have been present, so it's the denial to the self that anything bad really happened. And as a defense mechanism, as a coping mechanism, it's very easy to see why a person would want to do that. They're trying to minimize what it is that happened, to push that experience away, to go through life as if those things did not happen, is actually a fairly sensible coping mechanism to be able to just function in everyday life. If we look at the issue of structural dissociation within D.I.D, and one of the other videos describes this in greater detail, the apparently normal life can be gained by dismissing the emotional content of traumatic experience. So by pushing away the emotions, pushing away the narrative of trauma, a person is allowed to function in an apparently normal way. One of the reasons why a person might push away trauma, might deny the existence of their own symptoms of dissociation, is to protect themselves, to protect a family member who may be a perpetrator. It might not be safe to disclose the issues that have gone on. So to deny that trauma might be to protect self, to protect other people. It could be that they fear retribution from a perpetrator, from an abuser. It might be a very close family member, and it's simply not safe to be able to disclose the events that have taken place. For some people it might be an inability to fully immerse themselves in the depth or the horror of their trauma. So to just not be able to do it without something terrible feeling like it was going to take place. For some people, denying symptoms reduces the fact that anything is actually wrong. A person may be experiencing symptoms of D.I.D. They might have ulcers that are emerging, they might have loss of memory, they might have terrible issues about buying things that they don't want, that they can't remember buying, about losing things, about not being in control of where they are in time or place, about not feeling real in the world. And yet, to not want to have these being made open, a person might might be afraid that they're going to lose their kids, they might be afraid they're going to lose their job or their driving license as a result of these dissociative episodes, and they might be terrified, genuinely, that by talking about this, by accepting that these are actually a problem, that they're going to have to do something about it. As a coping mechanism, then, it allows the person to minimize the risk of them being caught having D.I.D. for fear that actually that means that they're going to be blamed for whatever happened, they might not be believed for whatever happened, or they might be punished for talking about it. Some people might also think that by acknowledging the presence of D.I.D. symptoms, about having alters emerging, means that they're going to have to do something about it. And isn't it better to just pretend that nothing is there so that they can just get on with everyday life? To do something about it means to have to take on the challenge. And I'm sure that this is true in many, many walks of life where a person absolutely knows that by acknowledging the existence of a problem, it means you have to tackle that problem. So denial takes place in all walks of life, in all walks of society, in relationships, in jobs, in medical, physical issues, and in mental health issues. So denial is an ordinary system. It's a defense mechanism against the need to have to actually take action. What this really means is that we have to understand the nature of denial for an individual at that unique level, without judgment and without criticism. To accept that a person denies for many, many reasons. Some of them may be very, very good reasons, and some of them might just be simply disastrous for the person at that individual level. It's really important for us as clinicians to be able to accept that position and allow people to have their denial discussed without them feeling like they're going to be shamed for it. One of the problems is that denial actually causes a great deal of difficulty. The longer a problem is denied, is pushed away, is forced away, the worse the symptoms can actually become. So a person might start off with fairly mild symptoms of D.I.D, as it were, so not great intrusions, and actually by the time years have gone past, these intrusions, the sense that the alters are coming out, the loss of memory, the intrusive experiences, all of these things can get worse and worse and worse and become incredibly debilitating. And as things get worse, the shame of what happened and the guilt of not speaking out becomes worse. That a lot of people, when they come out and say something that happened to them many, many years ago, they're criticised for not having spoken out sooner. Why didn't you say something earlier? If it was so bad, why didn't you do something about it? Now, if this trauma is occurring in childhood, that person may not be in a position to do anything about the experience, about the abuse that they may have suffered. So they don't say anything, and then it sort of becomes a habit to not say something, and then to begin to say something 10 years, 20 years, 30 years, 40 years down the line seems like an impossible thing to do if they feel they're going to be challenged with this narrative of you should have done something about it, and then the person becomes blamed for not having spoken out immediately, when actually it may have been incredibly dangerous for that person to have said anything at the time. Their perpetrator may have been living in the same house, and they may only be able to speak about it many, many years afterwards, for example, when the perpetrator has died, or they feel genuinely safe enough to be able to do so. What I guess it ends up with, though, is that denial means that a person doesn't ask for help, that they go through the whole life trying to make do as the best as they can do. One of the questions that has been asked is then, what causes denial to end? What is it that makes a person seemingly suddenly decide to act on their experiences, to take account of what's happened, and to walk forward to a GP or to a caregiver or to a family member or a friend and say, this happened to me and these are the experiences, this D.I.D, these alters that I have in my system, this stuff that I have going on in my head, these thoughts, these images, these sounds, these memories, they are overwhelming me and I need to do something about it. To take action and walk towards trying to get help for this. What causes that? We can see sometimes that what leads a person to take action about the trauma that they've sustained and the symptoms of D.I.D they're experiencing sometimes is a life-shattering event. Again, in my clinical experience, sometimes what I see is that a person might have an accident or an assault, later on in life, and that is what almost triggers the emergence of these dissociative symptoms. So the person has had these symptoms for many, many years, but they've been largely dormant, or the impact of them has been minimized until something happens, like being assaulted in the workplace or going out, or it could be the death of a friend or a loved one. It could be the death of a perpetrator. It could be finally realizing that that person is no longer alive, and that makes it okay to come forward. So sometimes it could be a traumatic event, or it could be a significant life event. For some people it might be having a child. That child is born and suddenly they become a parent and they're responsible for another life, and that triggers that sense of what it was like for them as a child. It could be that the age that that person experienced abuse was 6 years old, and it could be on the child's 6th birthday. That's when the traumatic dissociation starts to emerge in a much more paralyzing and debilitating way, because they're connected to their child's age, and that brings about the memory for themselves. One other thing, which is a little bit of an odd one, but it does happen a lot, is that none of those things have happened. And instead, the person's life is doing well. The classic question is, why now? When everything is just going well, why does all that stuff from the past suddenly come back to me and take over and haunt me? And that's because the brain has decided that the person is ready to take it on. Their life circumstances are good. They might be safe, they might be secure, they're well resourced, they have good people around them, they have a good life, and the brain that has been holding on to all this trauma for decades has made the decision that you are now strong enough to be able to withstand what that trauma actually means. Another reason that a person might suddenly realize that their dissociation is something they need to take account of, that their trauma has to be discussed, is when a person asks the question, what happened to you? And it might be that that gives the person permission to say something, or that that person is in the assessment and a member of staff, like clinical team like myself, who understands dissociation, spots a symptom. They spot a shift in that person's function. It could be that there's a gentle shift from the person to an alter. It could be just a momentary thing, or it could be something a little bit more obvious. But if someone like me is there and they are trained to spot these things, and that is discussed, it might be for the first time ever that that person has had their alters seen and noticed. And having that validation of them being seen and believed can allow the system to emerge. Again, it's about dormancy. If a person has held those alters back, they've denied the existence of them to themselves, they've pushed them away for years and years, and suddenly someone says, I see them and I am accepting of them, that might be the thing that triggers the emergence of a great deal more dissociation, and then finally lead to the diagnosis. Denial can occur for many reasons. The timing of the diagnosis for a person is purely individual. A person should never be blamed because they've taken 20 years to talk about experiences, symptoms that they've had. It's when the time is right for that individual, either through circumstances have forced the issue, or they've realised that they are now able to discuss it. And it might be because more and more people are becoming aware of D.I.D. now, that finally there's someone to talk to. If a person was going to their GP and trying to describe their dissociation and explaining how their D.I.D. was impacting of them, and that being dismissed as a borderline personality disorder or emotionally unstable personality disorder or psychosis or schizophrenia, it's going to make that person pull back and push those symptoms away ever further. So the responsibility is on us as clinicians to reach out and give people the opportunity, the platform by which they can discuss their internal experience in a way that's going to be believed and held. And ultimately what we want to do then is achieve help for that person. So being able to come forward, being able to feel that the person that you're talking to will believe you and listen to you, that they will accurately define and determine the nature of that dissociation for you, and then lead you towards treatment. That is the key. So we have to be thinking, what is it that we can do in terms of the questions that we ask to enable that person to be honest and open about their experience without judgment, without criticism, and without disbelief. And then we move them towards treatment. And then within that treatment, ideally the D.I.D. can be spoken about very openly and allow that person to find some sort of peace in the experiences that they've had. I really hope that this video has been useful. I hope it's answered the questions that people have put on, so please do keep asking more questions and posting more ideas for future topics. As always, please like and subscribe. Thank you very much for listening today. Take care, and I will see you soon.